Too heavy dose.
I'm Wael Jarjour, rheumatologist at Ohio State University. It's a pleasure of talking to you for the next hour, and learning from you, and hopefully teaching you a few things along the way. I'd like this to be very interactive, so if you don't stop me and ask me questions, I will be very, very disappointed. Okay? So ask questions. All right, so I've been given a very, very vast topic to cover. I'm going to do my best to cover it, but like I said, the most important thing to me is to answer your questions. So that's what I'm going to do. So I have no financial disclosures that are relevant to this. I talk about only Food and Drug Administration approved drugs. My talk will be about 2 minutes. So I will be talking about lots of things that are not true, but it is very true. Sadly, it is true. Whenever I give a talk like this, I always like to start with the, sir,
can you make closer to the mic?
I am not as loud as I think I am. Is it working?
I don't think it's on.
Real close.
Real close. Like the singing. Not good. Okay, so basically, if I don't talk about non-pharmacological therapy in myositis, I'm really sort of giving you half of the story, because in medicine we are learning the importance of things that don't come in the pill form in a big way. And it makes the difference between somebody doing extremely well and somebody not doing so well. So we're going to spend a few minutes talking about that. The first thing to talk about is rest and exercise. And since I gave my talk, the first talk this morning at 7 o'clock, I had a lot of people come and ask me questions about this, because when I trained, we used to tell our patients with autoimmune disease what you should do for the first month or two after diagnosis. You just sit around and do absolutely nothing. It's not good for you to do anything. Well, there's nothing more wrong than that. So we don't do that anymore. And so the idea is to find a balance, a regimen that works for you. And I tell my patients basically, you start small, 5 minutes, 10 minutes, maybe 3 times a week. You tolerate it, you increase it, you keep increasing it until you can do maybe 45 minutes 3 times a week. You do well with that, after a while you can do even more. You can do it more days of the week. Actually, it's very, very nice to try to do something every day of the week. But we start with something not very ambitious initially. So balance of rest and exercise. And I tell my patients, you're the driver. Nobody should be telling you to the umpteenth degree what you're doing. You need to do what works for you. And if you're going to do something crazy, as my patient, I'm going to tell you, if you have a spine fracture and you tell me you're going to go ride a horse, I'll tell you, maybe that's such a good idea. But short of something like that, there's a lot of wiggle room. So the patient needs to be in charge of this and decide what's good for them. Diet. So there are books written on diet and autoimmune diseases, and maybe a small amount of those books are based in facts. A lot of them are based in opinions and not facts. So what I tell my patients is, eat a heart healthy diet, lots of fruits, lots of vegetables. There are lots of food that have anti-inflammatory properties. There is no question about that. Don't eat it in a pill form. It's tasteless when you take it in pill form. Put it in your food, just like the way people did it for millennia. So don't go after the cheap way. I'm sorry, somewhat the American way. Everything has to come in a pill form. If you want to eat curcumin, eat the spice. India and Asian countries have been using it for centuries. It does have anti-inflammatory properties. So I think that's a food I like that. Just eat it in moderation, incorporate it in your diet, eat a lot of fish. All these things are good for sort of getting the immune system to calm down. But the main thing is eat healthy. And the diet is really, really important, because one of the things we do on Saturday for our patients, we give them prednisone. They gain a lot of weight, and if they don't manage their diet, it's terrible. So you really need to be proactive about that. And so the last thing I wanted to talk about is stress management. So stress management is, again, some of my patients come to me and basically want to ask me a tricky question. Do you think this is in my head? What? What? So you have dermatomyositis. What do you mean this is in your head? So, well, there are lots of other things. I'm anxious on this and that and the other things. I said, there is no separation between your psyche and your physical being. It's all one thing. So you ask me to split hair and tell you this is this or that is like almost silly. So basically, you need to address the whole person. If your life is stressful, find ways to relax. Make time to relax. Do yoga. Do something that you can do that doesn't require a lot of, whatever technique you would use to basically try to relax, meditate. It's very, very important that you do that. Take care of yourself, because if you're really stressed out, your immune system is very heightened. I do research. I'm a basic scientist. Even mice with autoimmune disease do horrible when they're stressed out. So people do actually much worse than that when they're stressed out. But basically the idea is this is not something we're imagining. This is real. So you need to do whatever you need to do to try to somehow de-stress yourself. I say that to myself because sometimes it's very hard to de-stress yourself. And removing the stress is harder than it seems, harder to basically say it and do anything about it. But you have to try to do what you can to reduce your stress level. Any questions so far? Wow, everything is either clear as can be or not clear at all. So anyway, all right. So continuing the thread of discussion about non-pharmacological things, we need to remember that the disease, autoimmune diseases and myositis of any kind, is a systemic disease that affects lots of things. It doesn't just affect your muscles. It doesn't just affect your skin. It doesn't just affect your lungs. So there are lots of things that need to be done. So one of the most important things that need to be paid attention to is cancer screening. Some of the dermatomyositis that are specifically very, very high risk associated with that. I just basically 3 months ago saw a patient in the hospital. She had dermatomyositis. There was no question that's what she had. And we basically said, do the screening. There was absolutely no sign of anything at the time. She would tell you she's very healthy, she's athletic, she's like in her 50s, she runs marathons, everything is great, until the rash appeared. But she had ovarian cancer. And if we didn't do a thorough job screening, we wouldn't have found it. So it's very important. But it's not just up front. It's, you have to be vigilant regularly with these, and some of them more than others. So work with your family doctor, work with your primary care physician, work with your rheumatologist, neurologist, all the doctors who are taking care of you, to devise a regimen that's appropriate for you. And there's no, yes ma'am?
You talked about having cancer screening in the beginning and being vigilant. Is it true that your risk of cancer actually goes down, like as you get further away from your initial diagnosis?
Sure. Yeah, that is correct. But have I made the diagnosis, not myself personally, but somebody helped me get diagnosed with cancer, a patient I've taken care of for a number of years. If the cancer was not apparent initially, absolutely. But it is, yes. So this patient, like we made the diagnosis of ovarian cancer like literally about 6 weeks after I met her the first time. Yes, ma'am.
When you say cancer screening, what does that actually entail?
Okay, that's a very good question. Also, that's a good question. That's a good question. So there's no one size fits all. Okay, so it's all the threshold. So for some folks, in some situations, when we do what we call what's appropriate for that person's age. So sometimes colonoscopy, sometimes mammograms, sometimes other things. But when we are really suspicious, like in the patient with dermatomyositis, I actually do a lot of additional testing. I do CAT scans of usually the pelvis and abdomen. If they're smokers, I do chest CT. I do a lot of, again, it's tailored to the patient, so there's no one size fits all, but sometimes there are a lot of other tests that are done.
I had the one that's more cancer antibody, one that's breast cancer. But my oncologist is just following me for breast cancer. What's the chance of me getting another?
I mean, it's very difficult to give you an answer to that. Is it possible for patients to have more than one cancer? Absolutely. Is it common? No, it's not common. It's not common at all. But it can happen. I mean, that kind of thing can happen years later. It doesn't even have to be immediately. I saw another hand. Sorry, go ahead.
My question is in relation to this. So my rheumatologist, I just saw her and she said, oh yeah, I think you should do check for cancer breast. And then my primary doctor said, oh no, she's out of the 3-year window, so we shouldn't worry about that. Because the way I see it is, when you have rheumatoid, you are at risk to have cancer. So why would I stop? And I know I don't want to get all of the cancer cells and the right and stuff like that. But at the same time, I want to make sure that I don't have any cancer, right? So
yeah. So that's a very, very tough question and very tough to answer this question because, like, I can't tell you how many times I talk to my patients. Of course I can do another CAT scan. Of course I can do another mammogram. It's easy for me. I just push a button and order the test. But to you, I'm exposing you to radiation that maybe 10, 15 years down the road is going to actually be something that's going to increase your risk of cancer. So we try the best we can to do things that are screening tools that really not going to increase the patient's risk of cancer. So whenever we use ultrasound, we use ultrasound. Whenever you use MRI, we use MRI. So we try to get creative if we think that screening is appropriate so that we're not increasing patients' risk of cancer. But again, it's like you have to be vigilant. And it's again, the question that was asked was a very, very good question because the risk does go down with time. But it doesn't really go back down to zero. Like, well, zero is never zero. It's actually comparable to the age group for that person. So it's not zero. But when can you go back to being screened like if you didn't have the disease? Well, that's a while after you diagnosed it with me, several years. All right. So the other thing I want to mention here is basically cancer screening is not just related to just you have very bad luck, you have myositis, and you have cancer associated with myositis. There are cancers that are related to things that the doctor is doing that actually increasing your risk of cancer. So I can tell you that there are patients I've taken care of over the years that I put on immunosuppressive medication, and I'm confident, sadly confident, that the drug I gave them predisposed them to certain kind of skin cancer that they otherwise wouldn't have had. So it's like, so basically I say if somebody has been on immunosuppressive for a long term, a dermatologist needs to be involved in their care. So basically periodically they're getting screens for melanoma and things like that. That's part of the routine that I tell my patients, that it's not just me seeing you, it's not just your family doctor seeing you. They usually, most family doctors are not comfortable with doing that screening, so dermatologists need to get involved. So anyway, so all that to say is that what we do can affect this risk also. Vaccination. So it's really, we're giving patients drugs that suppress their immune system, so the risk of many infections goes way up. The vaccination is a way to reduce some of this risk. The only thing I always tell my patients whenever I'm having this conversation with them, the one thing you gotta tell you, whoever's giving you the vaccine, is this a killed vaccine or is this a live vaccine? If it's a killed vaccine, it's a no-no. I basically say to my patients who are really immunosuppressed, you really need to avoid any live vaccines because the risk is great for getting into trouble from a live vaccine. The best thing to do, which often we don't have time to do, which is to give all the vaccines before we start the immunosuppressive regimen. We most often don't have that luxury. We can't do that. We can't wait. We have to do it. That's vaccination. Bone health is another issue that the disease plays a role in, but also the drugs play a role in. Prednisone certainly increases your risk of osteoporosis substantially. Naltrexone can increase the risk of osteoporosis. Lots of medication we give patients can increase their risk of osteoporosis. So that's one needs to be vigilant with that. So somebody who normally you don't even think about the risk of osteoporosis, let's say a male who's in their 30s or 40s that has myositis and been on steroids, you need to do the screening for them because that's important. And calcium and vitamin D, whatever the patient we need, we can talk about that. The first group asked a very good question, which is, well, what do you do if somebody has calcinosis from the dermatomyositis? Do you tell them to take extra calcium? In those patients, or if they have kidney stones, I say just keep a healthy diet. I don't give them any extra calcium. If they're vitamin D deficient, I replace them. If they're not vitamin D deficient, I discourage any additional supplement of vitamin D. Cardiovascular risk, that's again another conversation that rarely normally occurs because some of the patients we have with these autoimmune diseases, young people that normally this is not on the radar. But anybody, a 20-year-old who has an autoimmune disease has some risk of cardiovascular disease if they're 30 and they've had this for a while, then basically the risk is even greater. And so young people need to be screened, older people need to be screened, middle-aged people need to be screened. If somebody has an autoimmune disease, they need to be vigilant as far as cardiovascular risk. Yes, ma'am?
What kind of cardiovascular screening?
So I don't go crazy with that. So basically all I ask is that their lipids get checked, make sure that their blood pressure is okay, make sure that they're not smoking, the consequences of smoking, those kind of things. I mean, there are a lot of things that can be done additionally if appropriate, and a primary care physician or a cardiologist can decide that. But those are the basic things. There's really the literature on that. Initially, there was a lot of excitement about that. Then later on, there's really not. I mean, if somebody is deficient, it's important they get replaced. But high doses, the heroic doses of vitamin D, and I mean, I've seen people get toxic from vitamin D. It's not soluble, and it's not water soluble. So like vitamin C, you can give somebody whatever you give them, it just comes out. The vitamin D is not like that. So yeah, I would not recommend that.
About vitamin D, is there nuance or more benefit to certain types of vitamin D?
Whatever can get your level back to normal is the right one for you, because some patients you give them one kind and they just we check their levels and nothing happens. So
try one test.
I mean, most times people give hydrocortisone 50,000 units once a week for 12 weeks and try to replace with that. If it doesn't work, then you can go with vitamin D3 and things like that. But you don't have to stop with that. I mean, in calcium, it's very rare. I've only seen it ever once. But I mean, people are, when they're taking like 5,000, 10,000 units every day. I mean, it's not easy to do, but it can be done. Yes, ma'am.
Do you ever recommend doing like a bone density scan?
Absolutely. That's part of it. I mean, I'm not a lot of things I'm just going over very quickly because it's the first I view for everything I'm talking about. So absolutely. So basically, anybody who's been on steroid or going to be on steroid for longer than a couple of months needs to have a bone density as a baseline, and then needs to be repeated. And most insurance carriers will pay for it at much more smaller interval than normal, which is 2 years. It's like normally they only approve it for somebody who's like 40 years old. But because of the steroid, they will approve it. Not only that will approve it, they'll approve it like increased frequency of screening, so you can do it potentially at 6 months or 12 months to see if there's anything changed already. Yeah, absolutely. Very good question. All right, so we talked about a lot of important things, but the main subject was going to be the medicines, obviously. So we get to the medicines now. So steroids is basically the number one drug that we prescribe. I mean, I don't know of any patients I've taken care of that I don't start with steroids because it works fast, it's effective for most folks, at least in high doses, and it's a way to make things better for the patient quickly. Obviously, we'll talk a little bit more in details about that, and then all the side effects, all the issues, and how to do it, and these kind of things. Immunosuppressive regimens, we're going to talk a little bit more details about some of the categories and things, but I'm just really mentioning names. I'm not giving you a lot of the detailed information about anything, but I'm happy to answer any questions you have about any of them specifically. We'll talk a little bit about IVIG, then we'll talk about biologic agents, and then I always like to say something about research, because are we doing better than we used to do basically when I trained as a fellow, I don't know, almost 30 years ago now? Absolutely, no question about it. Do we have room for improvement? Oh my gosh, yes. So that's the reason people like me and many people who will speak at this conference, we do research, and that's why we do basic science, and we get involved in clinical trials and different things to try to improve what's available to our patients for taking care of the various diseases they have under the category of myositis and myopathies. So we'll start with steroids. And so, like I said, this is what almost all rheumatologists, neurologists that treat myositis do, is they start patients on steroids. The dose can vary from individual to another, but most of the time we use somewhere between 40 and 60 milligrams as a starting dose. We go with that until the CK falls, and then we start tapering. But sometimes the CK never actually goes back to normal, and that's basically a clue that either the CK is not a useful marker in that person, or it's that the patient is resistant to steroids, which actually is common up front. Sometimes that develops over the years, but up front there's only a small minority of patients that don't respond to steroids. So that's a clue for the treating physician that they need to add another drug to the patient's regimen to try to control their disease. Yes, ma'am?
When you get to a CK, it's like 400, 500, 600. Would you consider that kind of normal, or would you still worry about it?
Excellent question. Do I worry about it? Always. Can it be okay? Yes. So basically, I've had patients with myositis where no matter what I do, I can stand on my head and whatever, and their CK will not drop down below like even 1,000. And no matter what I do. But the main key here is, do they have active inflammation in the muscles? So in those situations, most often I go to another test that's much more reliable to tell me that there's active inflammation or not. So I either do an MRI of their muscles to see if there's inflammation, or I do a no conduction test. Occasionally I ask for a second muscle biopsy, because I certainly do not want to be under-treating someone because I think they're okay. That's not good enough. So sometimes I go all the way to a muscle biopsy and have a question that, does this 500 CK mean something or not? But then if I decide in that particular patient doesn't mean anything, then I follow it, because if it goes up to 5,000, then it may mean something. But as long as I see it within that same range, I don't really do anything different. And I need to keep tapering steroids for that. So if the steroid is like, if you can give it multiple times a day, you get the best control. The only problem is you get the worst side effects if you do that. So giving the steroids frequently can be a very helpful thing in patients who are doing poorly to get their disease under control. But ultimately, what you want to try to do is make it one daily dose, or even go, when the patient is doing well, go to every other day dosing, which can even reduce the side effects even further. So giving somebody 20 milligrams of prednisone every other day is better than giving them 10 milligrams every day. So even though it's the same dose, because it's every other day, it allows the body to recover a little bit in between. But again, as far as the effectiveness in controlling the disease, 20 milligrams every other day is less than 10 milligrams every day. So again, you pay with these drugs in risk what you get in basically efficacy. So it's really sort of it's a problem, but that's how it is. So once they reach what we call remission, then we start tapering the dose. And basically, initially we cut it down significantly. Is this the magic formula that the best regimen in the world, and if your doctor is doing something differently, that's not right? No, of course not. I do different things for different patients, and this is not what I do for every patient anyway. So there is no one size fits all regarding tapering the steroids. The main thing is they need to be tapered. You can't be on 60 milligrams of prednisone forever. That's just a terrible thing to do. So if you need to be on 60 milligrams of prednisone for a long time, then that means you definitely need other drugs very quickly introduced so they can control the disease, so the steroids can be tapered down. So the tapering fast when you start. As the dose gets smaller, you slow down. When you go below 10 milligrams, it's painfully slow. Really painfully slow. Like I taper my patients 1 milligram per month. And they go, really? Really? And I say, yeah, really, really. I'm sorry to say this, but it is the way it is. And if I don't do it this way, we'll be back to 60 milligrams and do the yo-yo again. I don't like doing that. And they go along with that. So basically, the tapering of steroids is very tricky, and like I said, I prefer, if I can do it, to go to every other day, but I can't always do that. Yes, ma'am?
What kind of taper would you do below 5 milligrams?
So, again, good question. Depends on the patients. I've tapered people where I tell them to go down from 5, alternating with 4 every other day, and do that for a month, and then go to 4 every day. Or basically decide I'm going to do an every other day taper from 5 on, so it's 5, 4 for a month, and 5 and 3, and 5 and 2. So there are so many variations to the theme. The goal is to try to get the patients on a low dose. But going below 10 milligrams, you really want the patient to, like, especially 5 milligrams, they have been in remission for a good long time. I don't even attempt doing that, like below 5, until I know they've been in remission for an extended period of time. And then I try to do it. Yes?
How do you define remission?
Oh, yeah. Another good question. So, remission is, that means that they should be, there are no objective findings that suggest there's any inflammation in the muscle, no matter how much you have to go to prove that, to yourself and to the patient. So that means if you do an MRI of a muscle that the patient thinks still has weakness in it, you find no inflammation. You do an EMG, there's evidence of damage, but no evidence of what we call active inflammation by EMG. The CK, as already been asked, is not a very reliable marker. A patient could be in remission, they could have a CK of 1,000. So that's weakness is very tough, very, very tough. Because sometimes it's the result of damage done, and there's really nothing that anyone can do to fix that except to exercise and try to build the strength back, the muscles that have not been damaged sufficiently to compensate for the muscles that have been damaged sufficiently. So it's really, really a very good question, and it's really, you have to be very individualized. You can do a blood test or inflammatory markers and see, make sure there's inflammation in the blood and things like that, separate C-reactive protein. But really, it's a very complicated issue to see somebody in remission.
If you have a rash still with tomatoes, are you not in remission?
Yeah, so technically not. But can I, so maybe you want to ask me the question differently. Well, I'm going to ask it anyway. I can answer myself. So would I be willing to taper the patient with dermatomyositis that has a mild rash? And do I view that differently than I view active myositis or something terrible like involving the respiratory muscles or esophagus or something like that? The answer is yes, but I have a threshold. So if I'm tapering the steroids and then things are flaring up, obviously I'm doing the wrong thing, so I back off. But it's again balancing what you're willing to tolerate or what the patient is willing to tolerate for the risk of the medication you're giving them. And that's a good example where I may add another medication to try to get them off, get the rash to go into remission. So there was one question here, and now I'll go back here. Okay, go ahead.
Is it individualized, or how do you decide whether to taper every other day or a lower day?
So, I mean, I first, my goal is to get the patient off the steroids. So if I can do it daily and get them off, then I'm happy. But if I fail, I talk to them about, well, maybe we have to keep you on some dose of steroids much longer than you would like or I would like. And then I go to the other day. There are people who do it differently though. There are people who right away go to the other day rather than swear by it. Yes?
Have you done any work with hydrocortisone versus prednisone, especially in terms of people who are having issues metabolizing it, or in terms of tapering?
Yeah. I personally never use hydrocortisone, but the question about metabolism is that's something that we definitely see occasionally, where you give patients prednisone and nothing happens. You give them methylprednisolone and you see a response. Now, this is not supposed to happen very often, but in my experience, it actually happens. And I see patients that there's very, very dramatic differences between you give them prednisone versus prednisone. The body is supposed to metabolize prednisone to methylprednisolone to make it work. And some people, I mean, it's supposed to happen for people who have liver failure, but I've seen it in people who have nothing wrong with their liver. So, yeah. Somebody raised their hand.
I'm one of those. Gloomier than a fruitcake on prednisone. Can't drive over 5 milligrams. I'm a nutcase. Metron makes me happy.
Okay, so that's different.
That's different?
That's different. That's actually, you're experiencing a lot of effects for the prednisone because it's getting all the side effects. The patients that I'm describing, and your question is exactly that, is those patients, like they're not taking anything. They don't gain weight, they don't get better, they don't do anything. And so, yeah.
Actually, it's more in terms of where she's coming from, in terms of
having side effects?
Yeah, my wife is very small, and when she went on that typical dose, steroid psychosis happened very quickly.
Wow.
And so she was feeling better, but it wasn't controllable. So this is in the early days when you go to a dermatologist 30 years ago, and so they bounced her. And that ended up in the hospital. And luckily, methotrexate in those days, the liquid form was able to get her back. And she went to can't walk, can't swallow very quickly because of the. Yeah. But we found the same way, 15 milligrams of prednisone, and that was her threshold, and she wasn't able to, and it had terrible effects very quickly.
No, I do switch between prednisone and methylprednisolone often. So absolutely, yeah. Yes.
Do you often see in Expo how you treat patients with persistent symptoms that don't have an elevated CK?
Again, in those patients, I want to prove to myself and to my patients that I'm treating myositis, not something else that's masquerading as myositis. So even if I've done the evaluation initially, and there's definitely no question about the original diagnosis, then I basically, we try a lot of things, and the CK is normal, all the parameters are normal, but the patient is still very symptomatic, then I go back and say, well, we need to do X, Y, Z, either MRI, EMG, or some other method to say the current symptoms are definitely related to myositis. Make sense? Sure.
So I'm specifically questioning the use of steroids. One of your colleagues last night presented some of the data, and their practices is they use steroids in IVM. Is that a difference in philosophy, or because trying to figure that out?
Yeah. So I'll get to IBM again. So that's it.
So this is not IBM.
Well, this is okay. So this is general, and then I'll specifically say something about IBM. Yeah. Let's go back there. Yes, you ma'am.
Patients who have interstitial lung disease, how do you tease out that when you're treating and maybe the person you mentioned muscle-wise, I mean, you still withdraw the treatment as far as the lungs, or do you keep them on, keep the lung symptoms in?
Oh, so it's all determined by the lungs are a very, very high priority for aggressive treatment because, I mean, people's tolerance for a little bit of constant patches on their skin is very, very different than I can't breathe. So, totally appropriately so. So, if any vital organs are involved, it doesn't matter. It doesn't have to be more than one. If I understand your question correctly, maybe I'm not understanding your question. So, I treat them very aggressively with just a single organ that's important and significant, that's active, even if everything else is in remission, and that they are technically not in remission. You mean like the question you asked was like, okay, so how far are you going to go with aggressive treatment for a little bit of erythema in the skin? Well, I mean, yeah, maybe not very aggressive if that's all it is. So, but if it's a lung, different story.
And I know about this probably on a lot of conditions, but I just saw Dr. Fiorentino at Stanford, and once again, he's like, yeah, you're still on a lot, like, I'm on a lot of things, and I dose of them, and every time I try to okay, go back to flare-ups and stuff like that. So when should a doctor consider, because I've asked that question when I told my doctor, when should they consider changes on prednisone to something else? And in my case, for example, I lost a lot of weight at first when I got diagnosed 4 years ago, and now I'm back at my weight, but I've never gained like a huge amount of weight. And I've mentioned prednisone usually does that, and it didn't do it to me. And in the past, I used to think prednisone didn't do anything good or bad. I mean, did bad, but not good. Nowadays, I feel that it gives me a lot of energy. So that's something that I felt later on. But when should they consider changing maybe to these other kinds?
Well, I mean, I only consider if I have a patient that doesn't have like any side effects of prednisone. I can't see any effect with prednisone. There's things in the blood count that can tell me that, like, when somebody takes a lot of prednisone, their white count should go up. And I look at their white count, their white count is normal. And it was the same before I started prednisone. So these are all clues to me that, for whatever reason, it's not doing anything to that patient. But, I mean, if somebody has an active inflammatory disease like myositis, one of the signs that the disease is active is they don't gain weight on prednisone. Or they continue even worse yet, they continue to lose weight. So that means the disease is terribly not under control. So when they, like, even though we hate it, when they start gaining weight, that's not always a sign that the disease is under control. But if they're not gaining weight, it's like, oh, wait a second.
Yeah, because I started gaining weight when I was feeling better.
Yeah, right. So, yes, ma'am.
I've been declared in remission and off prednisone completely. Am I interpreting that you think I should still be taking a small dose?
No. That was wonderful. No. I mean, you see, this is the thing. Doctors actually don't remember the success stories. We only remember the not-success stories. So we only remember the patients that we couldn't taper off the medication. But that's wonderful. And there are a certain percentage of patients that can be tapered off all medications, and they are in real remission, not drug-induced remission. Like if somebody's taking methotrexate and they're in remission, they stay in remission, they're in a drug-induced remission. But if they're off the methotrexate and still in remission, that's a real remission. Yeah. And a beautiful thing, too.
We've been dealing with statin-induced necrotizing myopathy, newly diagnosed, and right now hearing different opinions whether just being an IVIG is okay, or do you have to add prednisone also?
No. So I'm very pragmatic. Whatever works. so you can say IVIG is so much more benign than steroids. If that works, fabulous. But I wouldn't wait months before you see it work.
And working means you feel better, not just that your numbers look better.
Well, your numbers, again, when we talk about feeling, we've got to make sure that the feeling is coming from active inflammation. I have a lot of patients who have problems, they're not feeling well, but it's not direct result of inflammation. So that's the problem. So again, you got to measure things that are definite, that suggest that the inflammation is still going on. Yes, sir.
the diagnosis is for this necrotizing myopathy.
Right.
And I've always celebrated the difference between the myopathy versus myositis as it's non-conditional on its being or is that
very, basically, you're getting necrosis of tissue. So it's really, I mean, yeah.
Inconsequential.
Probably.
Terminology.
Yeah, yeah. I mean, it's clearly a different disease. Don't misunderstand me. And the interesting thing about it is that some patients who have it have what looks like rheumatology have never been on statin drugs. So it's been early on labeled as statin-induced myopathy, but it's not always in people who've got statin drugs. So the way I think about that entity is that there are triggers out there besides statins that we don't even know what they are. That gets the cascade of events that results in that very aggressive necrosis of muscles and that whole phenotype. So yeah.
So it's reasonable, the IVIG alone is reasonable to try for a few months.
Would I do it in my patients? Let's put this a different way. Probably not.
Yeah.
But I mean, if your doctors think the details of your case can justify doing that, you know what? If you can avoid steroids, that's a great thing. I have no idea what time it is and how respectful of time I am. I guess we have time. Okay, so this is one of the few drugs that, besides corticosteroid, that's approved for myositis. It's really the data to support its use is minimal. So I'm not a big fan of this drug. Yes, ma'am.
So I have two questions going back to the steroids. What do you consider like a maintenance or a safe daily dose?
Maintenance of steroids?
Yeah. Like at what point would you say it's maintenance? It's okay for them to be on it for a year or two?
It's called the lowest dose I can give my patient, and they will continue to be in remission and be functioning and doing well. So sadly, for some of my patients, that's way, way higher than I'd like it to be. But I mean, I think if we can get a patient to take 10 milligrams of prednisone every other day and they're in remission, and like, I would have to put them on a lot worse drugs to get them off 10 milligrams every other day. I keep them on 10 milligrams. I say, look, if you want to get off this medicine at 10 milligrams every other day, we can try, but I have to put you on a lot worse medicine to get you off the 10 milligrams. Do I do it sometimes? Yes, I do.
So you keep them for years on 10 milligrams?
Well, I can think of patients that I'm giving them more than 10 milligrams every other day that have been on it for a long time, and every time I try to taper them down, but no matter what other drugs I throw into the basket, they flare.
And my second question was, do you have like an average on what percentage of patients are able to achieve non-medication remission?
Very small in my practice, but again, I see the most difficult patients, so my practice is very biased. Sir?
How do you accomplish it with a patient that CK is normal?
Yeah, so that's definitely something that happens, and it gives you one less thing to be able to look at and say, oh yeah, this is still pretty active. So there are patients that you can biopsy their muscles, they clearly have myositis, no doubt about it, and their CK is, that's you, okay? And their CK is completely normal. So you can't rely on the CK. So you rely on symptoms, and you rely on MRIs, EMGs, other things. Yeah. Yes, ma'am.
Well, I was diagnosed in 1991, and I tried all the other drugs, but right now I'm on Celsec, and my doctors try to go down, and I've been on 5 milligrams at least for all this time, and I can't go below that or I start having issues. And my one doctor took me completely off the Celsec, and then my rash just kind of came back with a vengeance, and now I'm having a really hard time trying to get that under control again.
So that you bring up an excellent point. So that's sometimes the trouble with trying to taper medication. Is sometimes like a patient is doing great on a certain regimen, and both the doctor and the patient have the very good idea of, well, what if we can lower the dose of these medicines? And there's nothing wrong with trying that. Nothing wrong. Have I done it? I've done it, yes. But the problem is, once the flare goes on, you can go back to what you were on before, and it doesn't work anymore. So the immune system is extremely tricky. It sort of learns new habits when you get down on immunosuppressives, and what used to work well doesn't work anymore. You have to go to another drug. So yeah. So the immunosuppressive regimen. So methotrexate is really the drug of choice for most. Again, a lot of the things I'm saying here, I'm going to make a disclaimer that they don't work for including body myositis, and this is to your point. So, but basically for all the other inflammatory myopathies that we treat, methotrexate is really one of the main drugs we use, and it's a drug that is effective for many patients. And we have people who do very, very well on just methotrexate, start on prednisone, then methotrexate, and don't need to do anything else. Hydroxychloroquine is not on this list, but we use it a lot also in the treatment of especially dermatomyositis, but even some patients with myositis. The mild drug that sort of calms the immune system down and reduces the threshold for inflammation in the body. Azathioprine, again, we use it a lot, especially when there's a reason not to use methotrexate. So if somebody, usually I avoid methotrexate if somebody has ILD. They have lung disease from myositis, associated with myositis. I generally don't use methotrexate because it can get very confusing. Is the breathing worsening related to the disease, or is it related to the fact I'm giving methotrexate and they're developing lung toxicity from methotrexate? So I generally do not use methotrexate if somebody has lung involvement. Cyclosporin is another option to treat patients with myositis. Again, all these drugs have some data, not anything really major or robust data to prove that they work, but from practice, they all work. Tacrolimus, and probably one of the most common drugs used besides methotrexate in treatment of inflammatory myopathies is mycophenolate mofetil that was mentioned. Cyclophosphamide is a drug that is highly efficacious. We try to avoid it as much as possible in using it because it really has a lot of side effects, and some of them are things that don't happen for 10 years, 15 years after you use it. So, talking about increasing your risk of cancer, this is definitely one of them. So IVIG. So really, IVIG is a great drug for treatment of myositis. It is really effective in many folks. It's a lifesaver. It's steroid sparing in many patients, and there are patients that you really can get them off the steroids on IVIG, and you don't have to give them anything else. So it's really wonderful. Usually without side effects. Yeah. When we have a drug that actually doesn't have any side effects, I will definitely retire. That doesn't happen, unfortunately, sadly. No matter how hard you work, all drugs have side effects, even IVIG. And rarely we see bad things happen even with IVIG. But that's not very common. Yes, ma'am?
Is there data showing a stroke has a direct result of IVIG?
Okay. So the closest I can tell you to that is basically one of my patients with myositis developed horrendous basically venous occlusion related thrombus formation right after, like a week after they got a big bolus of IVIG. So that's the closest thing I can tell you to that. I've never seen stroke. Yes, sir.
Can you address, if you have any experience using the sub-Q and what you think the difference in the mechanism is between IV?
Excellent question. So, so there is really no data on saying that the sub-Q administration of IVIG, well, IG, for patients with myositis is as effective as it is if you give it IV. The only thing that the drug companies can tell you is that the blood levels are very similar, very reasonable. The problem is the immune system is very tricky. And when you administer one substance one way versus another, you can have very different effects. Would I be willing to try it in a patient because of convenience of whatever? Yes, I would. But I would monitor the patient closely to make sure it works.
I can just tell you, my wife started IVIG 30 years ago.
Right.
And she had a lot of difficulty with it. I think partially just because of the volume, but she's been doing sub-Q for 2 years, and it's a night and day difference. Not only is she getting the benefits of it, but she can tolerate it, and the best part is she gets to self-administer at home.
That's great. That's great. Yes, sir.
To get back on his comment, IVIG, I've done now for a year, and in my case, my first one was hard. The side effects lasted over a month, but I had very complicated health, and we had to do it at a slower pace. My lungs and my heart are also affected. So the best location for me is always hospitalization. It's over an 8-hour process, but if you have a severe adverse effect from it, the slower is better. And I do it, my max is 100, and I have known people to be even less than that. But it is something that I have found now very advantageous. The slower is better.
I'm sorry?
Slower is better.
Yeah,
The rate
yeah,
of
yeah,
infusing.
Oh, yeah. So, I mean, there are patients who can, the fastest way to get them to the ICU is to give it to them fast.
Yeah.
Yeah, absolutely. Yeah.
I separate days with my IVIG, so I don't do them all in a row.
Yeah.
My order is for 150 grams over 7 days. I can do it in 2 or 3 infusions. And I do it at home and I do it slow after success in a hospital for a year.
I do mine a 3-day weekend, starting on Friday and ending on Sunday. And I also do it via port, so.
And I get meningitis from that. I did that.
But we have to do it slow. Do you know IL? Yeah.
If you do it that with, say, septic meningitis from the initial IVIG, what's the prognosis as far as, do you get that every time, or are you more susceptible to
I would
it?
say, so, I mean, if it was really bad, then you probably want to think about trying to, yeah.
I've had great success with ciproheptadine, Periactin. It's stronger than Benadryl, and I had 3.5 years between the meningitis and then a mild 2-day headache. 3.5 years later.
Mild headache,
Fine.
anybody will take that.
Yeah.
Yes, sir.
What's the difference between the IVIG products? Because I know that there was one IVIG product I was on, no headache, I was fine. It wasn't available anymore. They switched to a different product, and I can't tolerate it. I get massive headaches.
Yeah, so it's the process of how they purify the IVIG.
Oh, is it?
Yeah.
So there's different purifying agents used in
So
different.
it's the methodology. I mean, how they separate the eye. There's a lot of products in the blood when they like these are healthy volunteers that give their plasma, and then the manufacturer purifies the IgG, the immunoglobulin, from their serum. And so everybody's methodology is proprietary and belongs to that company. So there are fine details where I can tell you how I would purify IgG in the lab. I never use it on humans. I do other things with it. But the basics is straightforward, but there's a lot of details of how they do differently to make sure that the patient is getting a good product free of any contaminants and any infectious agents, stuff like that. So those are where the differences are, and that's what most of the time what causes trouble.
Can you also, in regard to some of these folks' questions, especially that one, talk about the fact that not all the IVIG has the same mixture of IgA, GC, and so on and so forth. And I believe also there's a saline version and like a glucose version that are very specific.
So there are lots of nuances and details that basically certain drugs cannot be given to certain people because they're also IgA deficient, and they get some of that. They can produce a massive reaction that you never want to see. But those are like very unique cases and unique conditions. But you're right, there are lots of differences.
Well, like she was speaking about, I know my wife early on when we were trying to figure out why she was having such a strong reaction was that certain brands, their makeup of the IgA or G was different. Sure. And some of the different concentrations seemed to be more reactive. And then also as she got type 2 diabetes, you started looking at, well, what's the main glucose that it's in. So having knowledge of that and checking that out does help sometimes.
Absolutely. So let's see. I want to get, it's 12 o'clock, but I want to get to the last slide because that's talking about the idea and I don't want to not talk about it. So biologic agents, I'm not going to spend any time on this, but there are many biologic agents that have been tried. Unfortunately, like while rituximab, I'm just going to, so TNF alpha blockers, really the data is, the large studies is not very useful, like rituximab and etanercept. That's not to say some particular patient cannot benefit from it, but largely they're not effective. Rituximab, the definitive study was not positive, did not reach its primary outcome, but there are patients clearly respond to this, and there are trends in that study that shows that it works for some people. So I still use rituximab in some patients with myositis. And I'm not going to talk about this. Combination therapy, we do a lot of this. So combining one drug that works a little bit with another drug that works a little bit, and together we can use smaller doses and reach a very, very good efficacy. So methotrexate and tapering is a good example of that. Also, we use methotrexate with a lot of the biologics. So those are combinations that we commonly use. All right, I'm going to skip that. We talked a little bit about that. No, let's get back one here. I'm going too fast here. Where is my that one more. It's usually the problem. Saying, my time is up. It's not going to work. Okay, all right. So to the gentleman's point, immunosuppressants generally and corticosteroid do not work for IBM. Now, that's not to say there is not an individual patient, even in my own patients, that I feel strongly that I was not having a placebo effect and thinking that the drug is working for the patient. I'm not talking about the patient, I'm talking about me, the doctor, having a placebo effect. It's called the placebo effect, where the doctor is convinced something's working and it's not working. But, so there are individual patients that this works for, but it's a rare thing. It's not a common thing. So there are many clinical trials right now that are promising. The thing that I am holding the greatest hope for in this disease is that someday we'll be able to treat patients with both immunosuppressives and drugs that inhibit the degeneration of the muscles. When we reach that stage, we're probably going to do well by our patients who have IBM. So, but the time is not here yet. So I've gone over time. If you have any burning questions, I'm happy to come here up front and I'll be happy to answer them. Thank you very much. Sorry.
I